Good afternoon, and welcome to the webinar, Using Apps in Clinical Practice, Practical Aspects. All participants are muted throughout the webinar. Please use the Questions tab to submit any questions. Questions will be answered throughout the webinar. And now we will have an introduction of our speakers by Dr. Marlene Mayhew.
Hello, everybody. I would like to thank the APA for co-hosting this event with the Coalition for Technology and Behavioral Science, CTIBS, and also in collaboration with the APA divisions 18, 19, 29, 31, 32, 37, 42, 46, 53, and 56. My name is Dr. Marlene Mayhew, and I have been focused on technology since 1994 at the APA, was where I started. I am the executive director of the Coalition for Technology and Behavioral Science, as well as the executive director of the Telebehavioral Health Institute. My guests today are Greg Rieger, who is the Deputy Associate Chief of Staff for Mental Health at the VA Puget Sound Healthcare System, and a professor at the University of Washington School of Medicine. His research is focused on the development and evaluation of innovative technologies to support service member and veteran psychological health. Also, Julie Chin is with us. She's a clinical and research psychologist specializing in the use of health technology to improve patient outcomes. She's worked in the Department of Defense for over 10 years and now leads the Defense Health Agency, the DHA, Connected Health Branch Education and Training Program. The Coalition for Technology and Behavioral Science can be found at ctibs.org. And I want to also thank Dr. Jack Tsai, who organized the APA divisions as the president of Division 18. The first thing we'll talk about is telehealth competencies, because our topic today about apps is focused on addressing some of the competencies and helping you understand how to use apps clinically from the perspective of developing your own competencies. So first, I'm just going to step back a little bit and talk about how competencies are developed and how they fit into the lineup of what goes on before we start developing professional services. So you'll see at the top are laws that are generally put into place by our legislators, and out of that, our regulatory boards decide how that is to be interpreted for our professions. And we have ethical standards that are developed by the professional associations and sometimes adopted by regulatory boards, sometimes not, depends on the state or the province or the country. Out of ethical standards, guidelines are developed, and at the APA, guidelines have been developed for several years now to look at telehealth, not necessarily apps, but telehealth generally, and there was some overlap with apps. Out of that, not out of guidelines, but further breaking down what everybody has to do with regard to all of the categories above are competencies. And if you will, the way I like to think about it is those are sort of the building blocks, the amino acids of what we should be doing. So it amounts to knowledge, to attitudes and skills that then can be measured. So out of competencies should come training, and out of training should come professional services, because as most of you know, we should be delivering services that are based on not only evidence, but also our knowledge and our interpretation of that evidence with regard to the person in front of us, or the family in front of us, or the group in front of us. So what CTIBS did was to organize a group to look at developing competencies, because nobody had done that in the technology-related world, and we came up with an interprofessional framework for telebehavioral health competencies that looked at the idea of competencies from the perspective of all the behavioral disciplines that we could find. And we had representatives of 6 different disciplines as part of that team. So we worked for 4.5 years and came up with 7 general domains, 5 subdomains, 49 objectives that should be addressed by a practitioner that wants to go into this kind of work. And out of that, 146 practices or competencies. We broke it down into novice, proficient, and authority. And that's why it took us that long. It was because we came up with a draft of it. We sent it out for comments to lots of different associations and groups and individuals. We got the comments back. It took us a year to integrate it. We really received a lot of comments. It was quite heartening to see the interest in the work that we had done. We integrated all of that again, and we sent it out again for comment and then integrated those comments. So it was a long process, but we came out with these 7 competency domains, of which mHealth and apps is one of them. So today we'll be talking about the objectives related to mHealth and apps, and here I've got them on a slide for you. So we've identified 4 of them, and I'll read them for your convenience, but they generally focus on what we need to do as a clinician. Okay, so that is to assess client or patient use of mobile health technologies. Are they appropriate for, is the app appropriate for what we want to do? Somehow I lost that slide. Here it is. Okay. And that can be, is the app appropriate? Is the person appropriate? Does the person have the finger dexterity? Do they have access to the app? Those kinds of things. And then selects a technology with a specific purpose and documents and monitors that. We'll talk about that here today. And then practices with an evidence-based technology approach. And that means looking at not only the data in the research or what we learn in groups like this one today, but also filtering it through our own minds and our own experience, and then applying it to the person and talking with them about it. So having a collaborative approach with them and doing that. And then, of course, attending to all legal, regulatory, and ethical issues. And if needed, given that we have a firm footing in the legal, regulatory, and ethical issues, come up with new approaches if we have to, if there is no database to support us yet. So with that, we'll start with our first discussion question here today for Greg and Julie, and that would be, why would apps be a relevant technology topic for psychologists across the APA?
Hey, Julie, you're muted.
I was just being really quiet. Sorry. Thanks, Greg. So I'm Dr. Julie Kinn. You can tell which one I am, not just because I'm female, but because there's no fire behind me. Greg is the one with the fireplace. So let's take a moment just to think about how you woke up this morning. So what woke you? Was it your kids, an alarm clock, your dog, your spouse? For most of you, I'm guessing it was probably your mobile device. These days, most of our clients, patients, or beneficiaries are waking up with an alarm on our cell phones. And so that means the very first thing you're touching in the morning is your cell phone, and probably the last thing at night too. And although that can be a little scary, that's not always a great thing, it also gives us an opportunity. We can leverage the fact that our patients, our beneficiaries, are carrying mobile devices with them wherever they go. It's the kind of thing where our beneficiaries would rather turn around and go home to get their mobile device if they forget it and be a few minutes late to work. What we're seeing is that our patients are already using their devices to help with health, although they might not think of it that way. So, for example, consider the last time you got sick with a new kind of symptom, something you hadn't seen before, or someone in your family. You probably didn't go immediately to the emergency room. You probably played Dr. Google at first and looked up similar images and symptoms online. You probably looked up websites that you trust. If it was an ongoing condition, maybe you even downloaded an app to help you come up with ways to track your symptoms. All of these are examples of ways that our beneficiaries are currently using health. They're wearing wearables. They're tracking data such as weight lifting, diet, steps. All of this is common these days. And again, I know there's arguments for and against how much we are using technology, but because it's so pervasive, let's leverage it for patient engagement, especially since there are some phenomenal evidence-based apps, websites, podcasts, other kinds of health technology out there. So for all these reasons, technology and mobile health technology, like the use of mobile apps, is totally relevant for psychologists across APA for a huge variety of health conditions.
Yeah, and I think I would just add to that, you know, as a psychologist in VA, many of us, and it's obviously not just in VA, but psychologists in many different settings are working to address issues of access to mental health resources. Many of our client populations are living in parts of America or Canada or wherever you might be, where there's a limited number of mental health providers to provide psychoeducation, resources, interventions, and mHealth opens up some opportunities to really expand resources in those ways. So, you know, it's a regularly occurring conversation for me and other leaders in VA, thinking about how do we get resources to our clients who are living in remote areas, rural areas, places where there are few providers. So mHealth has some promise there if we can address the many challenges to getting good resources into their hands.
And I'll just chime in real quick. Sorry, Marlene, one sec. So Greg, you used the word mHealth, and just to make sure everyone's on the same page, mHealth stands for mobile health, and that just means accessing healthcare using mobile devices like cell phones. And also, I know we only have an hour today, and it's a huge topic, one that Greg and I have devoted a decade of our lives to here. We, both of us in the DoD and the VA, have tons of educational content available for free for all of you. So after today's webinar, I hope you'll follow up with us and the links at the very end of the presentation to see some of our other resources.
I also want to add some questions that are coming in or comments that are coming in. So please feel free to type things in. If we can include your comments, then we will. But I can't promise that we'll answer every question. We already had many questions before the event, and we are very limited in our time. But nonetheless, let me just make a comment that someone did write in that it's not just for psychologists. Somebody wrote that she's a mental health nurse practitioner, and she uses apps a lot to strengthen the therapy component of the visits that she's having with patients. So good perspective. Thank you. Yeah. In the CTIBS Telebehavioral Health Competency Framework's clinical domain, an identified objective is thinking about how to incorporate mHealth or apps into client treatment planning. So how do you think about treatment planning with apps? Let's talk about that.
Well, I'll start with this one if we can go on to the next slide.
Okay.
Thank you. So bottom line here, in bold, the technology is not the treatment. The way we like to recommend treatment planning with the use of health technology is the same way we always do treatment planning. So that didn't work. So for example, let's say we have a patient who has post-traumatic stress disorder, PTSD. My first thought wouldn't be, okay, how do I get technology into their hands? My first thought is, what's the right treatment approach for this patient? Let's say the treatment team decides for this patient, prolonged exposure is going to be the appropriate treatment of choice and the patient buys into this treatment. Then I would explain prolonged exposure treatment and additionally give the option for technology to assist. Now, for those of you who do prolonged exposure treatment, you know it's a fantastic treatment for PTSD, but it does have a lot of homework assignments, tracking, recordings, etc. And fortunately, there is an app, the PE Coach app, which I think Greg is going to talk about more, made by the VA with help from the DoD. The PE Coach app would be an appropriate app to recommend to help assist with all of that. So the treatment planning isn't necessarily focused on the app. The treatment is still the treatment, no matter what. It's still prolonged exposure. The technology is just another modality to help provide this evidence-based treatment. In addition to considering, you know, what's the general treatment approach and where can technology fit in, I would also look at these patient considerations. The top one and the most important one is patient interest. Some of your patients are already going to be using technology, and for them, it makes great sense. Some of your patients are not at all interested in using technology, or maybe they use it just for fun and they don't want to involve their healthcare with their technology. So that patient interest is a really important part of the engagement. We don't want to be pushing our patients into unfamiliar or uncomfortable terrain simply because it exists. That said, for your patients who already are using technology, it gives us an opening. So for example, if I have a patient who loves podcasts and they're there for pain management, I would recommend an evidence-based podcast such as the Living Beyond Pain podcast to help them, since that's already a technology modality with which they're comfortable and familiar. For a patient like that, it probably makes more sense than reading a chapter about pain management. When I was in graduate school, we had a shelf full of good books that we would always recommend. And that's what my supervisor used, so that's what I used. But looking back, I realized a lot of my patients probably weren't as into reading as we were. And so there's other opportunities now to still get that information across. I'd also look at contraindications. Marlene, you mentioned this a bit ago. If somebody is recently recovering from a traumatic brain injury, of course, we wouldn't want to be pushing health technology for them, although for their caregivers, very likely. Also, if someone has a technology delusion, then certainly technology doesn't make sense. And if someone is prone to compulsive behavior, I'd want to be very careful in terms of how we're using it and the limits we're putting up. Or the limits we're setting out to make sure that they're not using it too much or too little. And finally, ability and logistics. Fortunately, cell phones, mobile devices, mobile computers are so much less expensive than they used to be, but unfortunately, they're still not universal. As well as the logistic component, I know in my hospital, there's not Wi-Fi yet, and I'm guessing that's the same for many of you in your clinical settings. So sometimes there are just logistic considerations that make it more difficult. We can't just assume that everybody has the same access to the technology. And Greg, did you want to add anything here?
Yeah, I think I just underscore kind of some of what you said by just highlighting, treatment planning is always a collaborative process with our patients. And that's an individual collaborative process with that person that involves cultural factors, their goals, their interests, their preferences, and certainly the literature in mental health has done a nice job in recent years of highlighting the role of preference and outcomes. And so all of these things interplay with the things that we like about technology or a given app that we may have preference for. It's really woven into the process of this collaborative treatment planning process.
So we've had a few other comments come in that I want to address. One is a request for us to share specific apps that we recommend. And we chatted about this beforehand because in the list of questions that were originally submitted, there must have been 80% of them were requesting a specific app for this or that or this or that. We don't have time to get in a lot of that, but also there are liability concerns for us recommending a specific one over another. And so just for the sake of practicality and reality here, we will be teaching you how to find the ones that are best for the person in front of you, because we're not in a position to do that. That's part of what we're supposed to be doing as professionals. So we'll be getting into that in more detail. Greg will address it. We also had another question come in that asked how a podcast reaches evidence-based status. So I think that might be bouncing off of your comment, Julie, about a particular one for pain.
Yeah,
Could you
I'd love to jump in there. Sure. Thank you for the question, because I'm always excited to talk about podcasts. So just like a book about evidence-based treatment written by experts can help deliver that evidence-based treatment, same with a podcast. So for example, in the Defense Health Agency, Connected Health Branch, where I work, we started a military health podcast program. We have several podcasts that are made by experts in the military health system. So a couple of them in particular I'd like to highlight. One is the Living Beyond Pain podcast. in which we interviewed the pain experts in the DoD and VA about 9 specific topics that relate to pain management, including cognition, emotion, movement, how to explain pain flare-ups to kids. Another podcast that is evidence-based that we produced is A Better Night's Sleep podcast. It won the People's Choice Podcast Award for Best Health Podcast in 2019. Woohoo! And in it, we interview sleep experts across the Department of Defense about listener questions. So the podcasts are based on the evidence. And in addition, we are now running a trial at Madigan Army Medical Center, Joint Base Lewis McChord, where I'm located, to see if the inclusion of A Better Night's Sleep as part of a short-term CBTI, Cognitive Behavioral Therapy for Insomnia group, will help promote patient outcomes. So just like a book that features written documents by experts, same thing with a podcast. It's just an audio medium instead of a written one, but it can be so engaging to our beneficiaries because for those of us who listen to podcasts, you get to know the host. Plus, you can access it in different ways. You can listen on your commute. And although many of us love to read, some of our beneficiaries would rather listen to content instead.
And I'd imagine there too, Julie, that it's just like when we were encouraged to give books to our clients, we were supposed to read them first. So I would imagine that with podcasts, it would be helpful to listen to them and see if these people really are referencing evidence, that they sound like they know what they're talking about. They're not just making it up.
Absolutely. Just like you wouldn't just pick a book off the shelf. You got to kick the tires yourself and vet it to make sure it's appropriate.
Yeah. We have another question that came in that I think is great, and it gives me an opening to talk about one thing that I actually added a reference for, and it's that the comment is now lots of treatment apps are coming out, but research consistently shows the active ingredient in change is human relationships. How do outcomes vary with changes in how much human support is added to the technology? And there was a publication that I became aware of just last week. It's by Wiesel and a number of other researchers. And I added as the last reference on our 4 slides of references here today. And what they found was, after checking many, many, many different studies, so it was a meta-analysis, is that a standalone app is not sufficient for behavior change in a number of categories that they looked at, and it was quite a few: depression and anxiety, and a lot of different ones. So it just was published. It was a 2019 publication, so it was just put out. I encourage you to take a look at it if you're interested in that. Okay, so let me move on to the next slide.
I'll briefly touch on this. Technology is phenomenal for many, many reasons. Just want to make sure that our viewers here are aware that there is evidence-based technology available to help with all of these areas, such as self-care. For example, the VA, DoD have produced apps that help teach diaphragmatic breathing, that help teach coping skills, assessment. There's a great study by Bush et al. Greg, you might be on that study too, that showed that self-assessment on computer versus written versus mobile app all give equivalent results. Psychoeducation, tracking such as sleep, wearables, mood with the T2 Mood Tracker app, with homework, as I talked about with the Prolonged Exposure Coach, and of course, maintenance of treatment gains. And just to double down on what Marlene said, none of these are instead of treatment. Apps are another fantastic addition to treatment.
Okay, so another question that we formulated for you is clients will sometimes tell us they have found an app that they find useful. We hear about an app that we haven't used. How can psychologists and other professionals effectively evaluate and select apps for use in practice?
Yeah, so I love this question, and it I think it dovetails nicely, Marlene, with your question earlier from viewers about what app to use for what, any given problem X. In other words, it's the most common question we get, which is, what app should I use for problem X, right? And so kind of thinking about how do we select apps, how do we evaluate apps, merits several minutes. And I want to unpack this in a little more detail here. One approach, and that's probably most common, is we hear about an app and we look it up in the App Store. And we'll take a look and see how many stars does it have, what do the reviews look like, and that's a reasonable starting point. But you can imagine what that basically tells you is if the users liked it, and if they had significant problems with it, that will often come to light. If a bunch of people are saying an app is crashing, you can see that in the reviews. But there's some critical information as psychologists or other disciplines that's missing from the reviews of users, right? Like, is it effective? Is it based on sound psychological principles? What is the privacy associated with this app? And because those things are missing, we need some alternatives. Now, one approach that's proliferated, and we can go to the next slide here, Marlene, is expert reviews, right? Subject matter expert reviews. And so there's a number of these. These aren't the only ones out there, but CyberGuide is a nice aggregator of reviews of mental health apps. A year or two ago, Division 56, 46, 2, and 1 put together a mental health mobile app review database. iMedicalApps.com is another one. And there's others, right? We can review these expert reviews of mental health apps. Again, is another reasonable starting point for those of us trying to identify a potentially useful app. There's shortcomings with this approach as well that is important to think about. So on the one hand, it's probably a reasonable approach for identifying apps as a starting point. But let's think about these sources in terms of a static review over time. It's a monumental effort to keep reviews of apps up to date over time. If you think about the thousands of mental health apps that are out there, to adequately keep an up-to-date review of the current evidence of apps. I mean, Marlene just cited a brand new meta-analysis, right? I mean, the evidence is ever evolving, and just as importantly, the apps are ever evolving. The updates to apps are ever evolving. Bugs are being fixed, new content's being added, new apps are coming out. And so it's a really monumental effort to keep these up to date. Let's look at an example of CyberGuide. It's just one example. CyberGuide's funded by OneMind. This is a nonprofit organization in brain health that operates out of the University of California, Irvine. And their goal is to provide objective information that's accurate. The Anxiety and Depression Association of America has partnered with them for some mental health app reviews. So, this is a group that we would look to do some nice work, and they do. But when you look at their criteria for app reviews, they have one of their many scores is for whether or not the software updates have been conducted recently. It's a reasonable proxy, right, for is there support for the app? Is it updated frequently? Is there support for the app? And so the best score is given for an app that's been updated in the last 6 months. And if there's been an update to the app in the last year, you get the second best score for an app. However, to kind of make the point about how hard this is, I want to thank my research coordinator, Shalane Porter. Out of the 171 mental health apps listed there, she went through and put down the date of the review in CyberGuide. And the average age of the review was 668 days. So it's almost 2 years ago. Only 19% of the reviews had happened in the last year. Only 6% of the reviews occurred in the last 6 months. So I think I want to lift up CyberGuide for their great work, not take shots at them. I simply want to highlight incredible challenges with maintaining up-to-date app reviews over time. And CyberGuide acknowledges this themselves in their disclaimer, where they say, we strive for accuracy, but you shouldn't rely on any information contained in this website. So we need a different model. We need an alternative model that can build on some of these other approaches. And thankfully, there's some very practical, useful app evaluation frameworks that any clinician can use. Simple, these frameworks that you can work through as a clinician to think through whether or not an app may be useful. And the one that I want to highlight here is this APA, and here we're talking American Psychiatric Association app evaluation model. And I want to give a shout out to John Toros and his colleagues who've just done phenomenal work in research of apps, and they helped develop this model. And the steps here you can see really involve gathering background information on the app, looking at the risk and the privacy and security of the app, considering the evidence. Step 4 is looking at the ease of use of the app, and then the 5th step is the interoperability of the app. So it's a simple 5-step framework that any clinician can work through. And Marlene, I'll give it to you there.
Okay. Before we get to our next question, we have a poll. We have 2 polls, and Sonia, could you help us with the polls, please?
Sure, one moment. Okay, the poll is now up, and you can go ahead and vote.
The question is, how many different unique clinical apps have you used in your practice? And please select one of the 4 options we've given you. 59% of the people have been using 1 to 5. About a third of the people have not used any. Let's see, we have 7% of the people that have used 6 to 10, and about 2% 11 to 15. So most people are either using none or 1 to 5. So just getting started. So it's great. It's good to know.
Wonderful.
And our next poll. Okay, so still 17% looking at the App Store reviews. Those, by the way, can be skewed because people can be hired to go answer or just go give star ratings. So those are a little bit questionable. Coming from clients, client recommendation. So like you said, Sonia, 51% colleague recommendation, and then 11% visited the behavioral app review website like you were talking about, Greg, and then 10% have gotten formal training. Do you want to comment on these results, Greg, given what we were talking about?
Yeah, no, I mean, I love it. In fact, I mean, we often hear about an app from, clients or colleagues. I mean, if you lump those together, it's the vast majority of app recommendations. And so to hear about an app like that, having an idea in your head, a framework for considering whether or not that's an app you want to consider using with clients, it's really, really useful. So we'll talk.
You're fading out a little bit, Greg. Yeah.
Thank you for the heads up on that.
Okay. So then let's get to this next question of how can you could you walk through a brief example for us as a demonstration, Greg, of using the app evaluation framework?
Sure, and I'll just build off that poll to kind of build the example here. So, I just walked through this APA app evaluation framework. So let's go through an example here. So let's imagine that you're a therapist who recently was trained to treat PTSD with an evidence-based psychotherapy called PE. And Julie references either 8 to 15 psychotherapy sessions to treat PTSD. You go to a 3-day workshop, you learn the skills, and during the workshop they say, hey, by the way, there's this app that you can consider using to help you out, make the treatment more convenient. It's built by the VA and the DoD, so take a look. So you leave the workshop and you're thinking, well, maybe this would be useful. And so you want to check it out. And given that this really, the context of the patient matters, let's consider a hypothetical 42-year-old woman who comes to you for treatment of PTSD. She owns an Android smartphone. She's comfortable using it in her day-to-day life, uses it with her calendar and texts with people. She's installed a few apps, but hasn't ever used it for a health or mental health purpose. And you're considering a discussion with her about whether or not to incorporate this into her PTSD treatment. So let's walk through this app evaluation model as an example as it relates to PE Coach 2. So the first step, of course, was that background information to give us some context about the app. So um, as we walk through these questions, and Marlene, here you can go to the next slide. Note that there's more questions for each step than I'm going to review here for our time purposes. You can go to the website on the earlier slide for the model to see them all there, but I'll just illustrate a few things here. So, in gathering the background, we want to know who's the developer. In this case, it's the Department of Veterans Affairs, and we read the description of the app. We see specifically it was designed by the National Center for PTSD, which, informs our confidence about the content. We ask, what's the cost of the app and what is the business model? How does the app support its own development? Here, it's free to users because it's developed by the federal government and it's supported by them. Is it a medical app? Does it claim to be medical? Well, PE Coach 2 is categorized as a health and fitness app, and it is stated to be designed for use during therapy for PTSD in combination with a health professional. We look at the platforms it's developed for, and we see that it's available for iOS or Apple devices and Android. Then we look at how recently it was updated, and we see for Android, it was updated in April of 2018, which is listed as the first release, but we know that PE Coach 2 followed about 5 years of PE Coach. So with that background now, we turn to step 2, the risk and the privacy as it relates to an app. So here we want to consider, is there a privacy policy? And if so, what data are collected? Are personal data de-identified? Who are the data shared with? And if the answer is that we're not sure, we look at the app and we can't tell, we probably can stop right there. The APA has designed this as a hierarchical set of questions. In other words, if you can't answer an earlier question satisfactorily, you can just stop, right? If we don't know what data is being collected or there's no privacy policy, we probably don't need to worry about other things because we're probably not going to recommend it to a client. In this case, for PE Coach 2, we see there is a privacy policy. It's clear. It states that no identifiable data is transmitted to VA, and we see that the data is on their device, and it's the patient's responsibility to ensure the security of that data after the app's installed. So we think about how we'll talk with our patient about that. Third step's evidence. Here we're thinking about, is there evidence for potential benefits? Now, there's a question earlier I think was alluding to, there's very few apps that have evidence on mental health outcomes. I mean, there's thousands of mental health apps, and very, very few of them have evidence for an impact of the app on outcomes. And so we've got to look at this and think, what kind of evidence are we looking for? And usually what we'll do is, certainly we can look at our academic search engines to see if there is evidence. We can also install the app and look at it and say, is it consistent with our own expertise of psychological principles? And, does it do what it says it's designed to do? Is it sensible? Is it fit? Is it based on evidence principles? And so for PE Coach, we look in PsycInfo and we find 5 relevant articles. Most of them are on usability, case series. There's no randomized trials of PE Coach on PTSD outcomes. So we install the app and look at it some more and see it aligns well with PE Coach. It does indeed have features that support the in-session and the homework, and it looks like it fits well with what you learned in your PE workshop. So we go on to step 4, ease of use. So here we're talking about usability. Is it easy to access? Can a client that we are thinking about using it with navigate through the app? Does the app need an active internet connection in order to be functional? And if so, is that available in your clinical setting? Are there culturally relevant factors to consider? These kinds of issues. If an app sits well within your psychological thinking of what it should do, but a patient can't navigate through it, we're going to be dead in the water, right? It's got to be a usable, functional app. Otherwise, it just is not really worth proceeding. And then the last step here is interoperability. And here we're talking about in the age of digital technologies, there's interest in whether or not these things can transmit data and talk to one another. Are there opportunities for the app to link with other devices, Fitbits, or other devices? Can we link to the electronic medical record? Will it transmit data to our clinician, the provider? Can you get access to the information if the app is used by your patient? And of course, all that sits within the questions of privacy and security and how that transmission happens. So you look in PE Coach and you can see that the data is not being transmitted. You're going to be looking at this screen with your patient side by side. You do see there's an option in the settings for a patient to email data off the app to you. And so you do see that. And so you take all of those steps, and then you can think about our 42-year-old client that we're about to do PE with, and think about whether or not PE Coach 2 is a good fit from your perspective as you go into the process of shared decision making with the client. And I'll pause there, Marlene.
Yes, we have some comments, Greg. First, some people had some comments on the platform. They wanted to know why there was not an option for the professional themselves to have reviewed the app by downloading it and using it themselves. And we had other options in there, but the APA platform only allowed us to have 5. Okay, 5 options for you to pick from. So we picked 5. But Greg, do you want to comment on that? Do you think that's a reasonable approach, is for someone to download it and try it themselves, see how it works?
Yeah, absolutely. If I didn't mention that, it was in my notes. Certainly, we want to install the app and look at it and examine it ourselves, and that's primarily how we're going to find out issues of usability, what the privacy policy says. Yeah, we've certainly got to take the time to look at it ourselves.
Yeah, and one of the things I've learned is
with a book. Just like with a book,
like,
even if you hear on NPR, this is a great book, you're not going to recommend it to your patient unless you've actually read it yourself. Same thing with a mobile app.
One of the things to look for is that on the bottom of the app, let's say it's on your phone, there should be about 5, no more than 5 options there as part of the architecture, because people will hit more than one. So little things like that can really get in the way and bog people down. If their fingers are too big, they hit 2 things at once. It's very annoying. So there's lots of little features like that you may want to think about. There's another comment that came in that said, I'm confused. PE Coach has 2.2 stars. PE Coach 2 has 2.2 stars. Users aren't liking it. Does that not need to be taken into account as well as other evaluation steps?
Yeah, I would. So I would certainly be interested in what users think of the app. I mean, my starting point for any technology is our users are never wrong. If we have built something that our users don't like, then our users aren't wrong, we are, right? As it relates to PE Coach 2.0, I haven't reviewed the usability data. The VA certainly embeds top quality usability studies, and our user reviews are going to be important. So there are things about PE Coach 2.0 that I don't like. And so, there may be that when we look at usability studies for any app, it's time to do an update, right? So no, I think that the things you want to consider is, as psychologists, we want to consider the data appropriately, right? How many user reviews are there? How many, what number of data sources are going into those star ratings? And then star ratings don't include key parts of information that are available in this framework. But yeah, usability and reviews online are one piece of information that certainly I'd be interested in.
I would add a caveat to that, just because of some of the things that I've seen, is that they can be, if they're skewed in any way artificially, they would be rated as too good, because people can pay people to go rate them good, but people rarely pay other people to go rate their own app bad. So I think user reviews can be taken into account if it's reflecting something negative. Also, within the review, there could be a fair amount of information about what they don't like, and it may not be relevant to what you're doing. So sometimes it's useful to read the reviews and actually see what's in there.
It's certainly not a scientific study, right? I mean, we're not getting a randomized sample of individuals to evaluate our app. So it has extreme limitations, but I'm also not going to ignore it.
Right. Okay, so I think we're ready for the next slide. How does a provider need to keep up to date with all the new apps?
Can I take this one, Greg?
Please.
Okay, so you can't because there are so many apps out there. It would be a full-time job of a huge team. There's so many coming out all the time. But again, I'll go back to that analog of books. Just like there's so many books coming out all the time doesn't mean we don't want to pay attention to some that are very highly rated. I think for those of us who are really into technology, this is a fun pastime. But for those of you who are just getting started here, I would hate for the overwhelming nature of the amount of apps out there to prevent you from getting started. So what my suggestion is to consider what are one or two of the main presenting issues you're seeing in your client population. Let's say it is PTSD. Then what I would do is on your own or with a committee of your coworkers, take some time to vet one or two really good, solid, evidence-based apps, along with one or two really good, solid, easy-to-read book chapters about PTSD, a couple websites that are very easy to read and evidence-based, maybe podcasts, other kinds of health technology. And make sure these are ones that fit with your treatment modalities, with your perspective, again, evidence-based, easy to use. And I make a handout, a flyer, so that when you have a patient come in who has PTSD and they might be more interested in a podcast or a book or a website or a mobile app, you've got these resources available. In the moment, you're not trying to decide, oh, what's the newest PTSD app out there? Instead, you know this is reliable information. And so you have new people join your team, you can help them get familiar with them, know what's happening with these apps, when they're good, when they're bad, if they need an update, for example. And then once a year, go back through and see, are these still the best? Or should I add a different app instead? And as you do this process over and over with other presenting conditions, you'll soon have a nice reference library for whatever the patient need is.
Yeah, and I think I would just add that, one given how many apps are out there, one nice way to keep up to date with apps is keeping an eye on the developments of key developers. In other words, given the importance of who develops the app to some of the questions we addressed in the framework earlier, it's nice to keep an eye on SAMHSA and APA and VA and DOD. Because some of the highest quality stuff will likely come out of these shops, and that way you can be alert to some of the better stuff coming out.
And you know it's evidence-based. If you see a new app come out of the VA's National Center for PTSD, you know already this is from a trusted source. Same with our apps in the DOD coming out of the Defense Health Agency.
So we're having more comments come in, particularly about privacy. So let's just talk about that a little bit more. I think people are concerned about the privacy issues. I know for a lot of the training that I've done, the focus has been on actual, how do you implement it in session? And one of the things that we've encouraged people to do is to help the person get used to it right in the session. So help them put the app on their phone, get it started. A lot of times there's a screen that opens up and asks them if they want to report bugs or problems to the developer. We may want to encourage them to not do that because, frankly, we don't know what that developer is going to be doing with any of the information. We're not there to check every line of code that gets developed and gets sent out to the developer. So maybe best for them to toggle that kind of thing off. So for us to walk them through that. Is there anything else, Greg, Julie, you'd like to add about more specifics related to privacy?
You want to go first, Greg?
I will. Yeah, sure. I'll go first.
Okay.
You know, I have to say, Marlene, like, I think this is really hard. I think the privacy issues are very, very concerning. Because if we don't know who the app is, developed by, excuse me, if we don't know who the app's developed by clearly, there's no guarantee that the privacy policy, if in order and to our liking, even accurately represents what is done with the data. I think this is an area that's really going to emerge in the coming years because there's a recent study that, again, John Toros and his group did, looking at how data was transmitted off of apps, and they don't often adhere to their own privacy policies. So there's some real concerns here, which is why I'm really, in my own mind, I'm starting to really emphasize the developer of the app and the trustworthiness of that developer as the key starting criterion because of some of these issues.
Yeah, I concur 100%. This, with the VA app, you know exactly how any external data is being used. You can choose to send data to be aggregated to help the VA track metrics, but it's toggled off as a default. In the DoD apps, it's not even an option. The data stays on the device. It doesn't go anywhere. But beyond that, we can't promise what's happening with other apps. That's part of that important vetting process and figuring out if it's a trusted source. I'm glad to hear this question. I think it's essential.
Yeah, we have a segue to that. Somebody asked, do we need to have somebody sign an informed consent document so that they can be sent the information through email? Or that we could be sent the information through email. It wasn't specific, but anyway, so that the information could be sent through email. Would one of you like to address that, both of you?
Well, I'll jump in to start. I think there's two separate issues here. One is informed consent in general to use health technology. At this point, APA doesn't have a specific recommendation about informed consent procedures with relation to health technology. But what I do recommend is an open discussion about health technology with patients and then referring to that in the patient record. So for example, if I'm recommending PE coach as part of prolonged exposure treatment, I would make a note of that in the patient record and also indicate the kind of discussion we had about it. If I'm in private practice and I have the ability to add a section to my informed consent about use of health technology or about social media usage, for example, I like to do that as well. But for many of us, we can't actually adjust our informed consent procedures. On the other hand is the issue of how to handle when a patient emails us. It's tricky. As soon as somebody emails you something, it's part of HIPAA, right? When the data is on the patient's device and they're the only one with access, it's not relevant to HIPAA. But as soon as it gets to you, it is. In the DoD, we made a decision that we would not allow any data to be shared from our app. It all lives on the device, in part to prevent this from happening. We want to make sure it's extra safe. We want all of our apps to be able to be used anonymously. And so it's awkward when a patient comes to session with an app like the Virtual HopeBox app. They would need to actually show the device to the provider to show what they've done. There's no data sharing there. The VA, Greg, you can speak more to this, I believe, has some apps that do have data sharing. However, it's using a secure server with two-factor authentication and a token network through My VA Apps, I believe. So this is very deliberate, very safe. It's not just, hey, here's my data, I'm emailing it to you. Greg?
I mean, where this is headed longer term, of course, is exciting. If a client of mine is using an app and I can log into a secure web-based portal and see in real time the homework that they're doing, if there are symptom reports, some really clinically relevant data, I mean, we've got some opportunities to enhance care in ways that are super promising. for at least VA. I think there may be other healthcare systems that are further along with this, but that's still in the future. And there are personal health portals like the VA has that veterans can interface with in a secure manner. And eventually these things will be linked so that the apps talk to those places and the clinician can see them. In the interim, you certainly want to use great and careful, appropriate caution in terms of privacy. In addition to everything Julie said, we got to consider your organizational policies on emailing with clients. For example, in VA, I know that I cannot email with clients because there's no opportunity for them to use an encrypted method of sending their data to me. So even if an app has that capability, I'm not going to recommend a client email their mental health data in my direction.
So we have 3 minutes left. Let me just help us move through the remaining. I know we could talk for a few hours about this, but these are very good questions. Obviously, we've taken them as we've gone along, so we're not going to be having a question and answer period at the end. But email is not secure. So for most email, I just want people to be clear about that. And you need to go through some processes having to do with informing your person about risks and benefits of using email before you try to use any unencrypted email. So let me move us to the next question. And then we're going to have to end. What are the practical ways to recommend an app to a client once you've identified one that you'd like to recommend?
Can you go to the next slide?
Next slide, okay.
So first, discuss it. Make sure they're actually interested. Demonstrate it. In an ideal world, we would all have a tablet with the apps that we want to recommend preloaded on it so the patient can feel it, can see the advantages of it without having to take the time to download it on their own, and then prescribe it. Here's an example prescription pad that we make in the DoD, has VA apps on there as well. If you download our PowerPoint presentation later and click on this link, you can get access to this. The other side is podcasts and websites, and follow up, just like you would with any other kind of homework assignment or other activity or other kind of prescription. Be very specific about how you'd like it to be used, and then make sure that you're asking the patient about it. Greg?
One moment, before anybody scoots out the door, I'd like to encourage you to stick around and fill out the evaluation for this program. It's very important so that we can keep programs coming your way. Yes, so Greg, you want to say something?
No, nothing to add. It's fine.
Nothing there. Okay. What about let's take this last question. I think I'll just move on to the resources that we've got. The reading list for everybody. We've got 4 slides of reading, and some people did ask about the meta-analysis that I commented on earlier, and it is the last one on the last slide here, because it's a W. Okay, so let me see if we have any other questions. Any apps in different languages? Let's take that question.
That's a great question. It's not my area of expertise. And so I really can't answer it, but I think that goes back to the importance of the cultural factors that interweave with these clinical decision-making issues. If we're working in a clinic that's primarily, Spanish speakers or other languages, those are critical questions.
Yeah,
absolutely.
Okay, then.
Most apps are able to be translated very easily.
Nice to know. Well, thank you very much to my guests, and once again, thank you to the APA.